I thank you, Dr. Wiviat, for that lovely welcome. I think we'll just get right into it. We have a busy night tonight. We're going to be starting the evening presenting some information and data for you, a lot of logistics that we're going to try to cover fairly quickly, because the point of this evening's discussion and presentation is to get to the point where we can share ideas and concerns, and that you all have an opportunity to ask your questions. So that being said, next slide. I work for the Coalition for Compassionate Care of California. And as Dr. Wiviat mentioned, we are a collaborative, and we work to improve quality of care in serious illness and end of life. We are a completely neutral body with respect to the End of Life Option Act itself, and we provide education and resources for patients, providers, families, and organizations.
Okay, with regard to Sutter Health's position, Sutter Health is going to be respecting the rights of our patients with regard to their end-of-life options under this new law. But Sutter Health is also going to be respectful of the rights of our providers and especially physicians with respect to this particular law. So, what we want to do today is to really engage in a conversation and explore the different dimensions of this new law. And we want to talk about its implementation. We want to teach you about the process. We want to go over some of the definitions, terms, key points with regard to the End-of-Life Option Act. We also want to talk to you about what is the spectrum, not just this particular option that is now being made available through the new law to the patients as well as providers, but what are some of the other end-of-life options that are available to our community of physicians as well as patients. So it's not just the End-of-Life Option Act, but it's also other choices under the end-of-life care. Dr. Duncan is going to talk about the experience in other states, specifically Oregon, because as you know, our law here in California is modeled after the Oregon law. And then last but not the least, we are going to go through some of the moral and ethical challenges with regard to this new law and talk about why are these issues so challenging to discuss. And with respect to that, I do want to emphasize that each one of us here, I'm sure we have our own opinions about this particular new law, and we want to make sure that we are all being respectful of each other's opinions and views tonight. You will all have the opportunity to ask questions, but we ask you to be courteous and to be respectful. Okay?
All right, so can you hear me? Is that working all right? What is this law? Very simply put, it gives terminally ill patients the right to request and receive aid in dying medication in the form of a prescription that will end their life. Next slide. Couple of key points right up front. Really important to know that this legislation is very complex. It is the most stringent legislation of its type on the books anywhere, and we are the 5th state to implement such an option for patients. All aspects of participation for patients, providers, and healthcare organizations are completely voluntary. And that's really important to know. Every step of participation and process is very, very detailed in its outline in the legislation. Next slide. So what is participation? Participation itself is defined in the legislation. So for each person who might be participating in the law, whether it's a patient or a provider who's fulfilling the role of an attending physician or someone who's fulfilling the role of a consulting physician, their roles and responsibilities are defined in detail within the legislation. Next slide. Who is qualified to participate? So some of these aspects of eligibility are very straightforward, and some are more nuanced. You have to be 18 years of age or older. You have to be a resident of California, a documented resident, and you have to be able to make complex medical decisions and have capacity for medical decision making. Terminal illness is defined in the legislation as 6 months best prognosis based on your stage of disease. Our legislation specifies that you have to have the physical ability to self-administer the medication. That is different from the Oregon legislation, which only says that you can that you have to ingest it. Our legislation says you must self-administer. Next slide. How does the process work? From the perspective of the patient, they have to submit 2 oral requests face-to-face with their attending provider, and they also have to submit a signed and witnessed written request. And there are specific forms for this as well. Next slide. Again, if you have questions about the logistics and the actual implementation, you may bring those up, but the point of our talk tonight is not to belabor the details of implementation or the process, but to talk more about the content and the intent of the discussions around this. So I am going over this quickly, I recognize that. How does the process look in general? Patient is submitting their oral request in person. They are bringing in their oral request. They have to be fully evaluated by someone who is participating and is taking on the role of the attending physician. The attending physician has to fulfill all the responsibilities that are outlined in the legislation according to that role. They have to refer the patient for a second opinion to the consultant physician, who has to agree with the diagnosis, the prognosis, and the patient's ability to make decisions around this issue. If either provider has any concern about the patient's ability to make decisions, then a mental health professional has to be consulted, and an evaluation of the patient's cognitive ability to make medical decisions has to be formally evaluated. In addition, the patient has to sign a form within 48 hours of ingestion, stating their intent to take the medication. Next slide. How is this very, very complex piece of legislation being implemented in healthcare organizations? Differently for different healthcare organizations. That's really important to understand. Every healthcare organization, like every individual or every person, or every group, has a different perspective on how care should be administered. You're all familiar with the mission and values of CPMC, the Sutter Health Center. Different organizations have different missions and values. They are entitled to make a policy around the End-of-Life Option Act that is consistent with their own mission and values, and to bring that to bear on how they direct their providers and caregivers to interact with patients on this issue. So not all providers can participate, and not all organizations will be choosing to participate. It's really important to know your own organization's position statement, their policy, and be aware of what your rights and responsibilities are in that context. Next slide. What other legislation is important to consider in this area? This piece of law was passed over 2 years ago now, almost 3 years ago, AB 2139, which directs all providers who are caring for patients with the terminal diagnosis, and in this context, terminal diagnosis is defined as an estimated 12 months of life left. They are required by this legislation to inquire of their patient whether or not they would like information about options for care in the end-of-life setting. And if the patient says, yes, I would like those options, then the law obligates providers to explain to the patient exactly what their different options are for end-of-life care. And that includes, on the next slide, a detailed discussion of their prognosis and how things might unfold over time, a detailed discussion of what palliative care is and whether or not it might be available and to what extent it is available for that patient, hospice care, life-sustaining treatments, and other end-of-life options. What is not necessary to discuss is this Aid in Dying End-of-Life Option Act. All right, this is a very specific option that is not considered to be part of this list of general options for end-of-life care. I'm going to let that sink in for a minute. So as a provider caring for a patient who in your mind has perhaps 12 months to live, whether it be from heart disease or cancer or a degenerative neurologic disease, it doesn't matter. You are required to ask them if they would like information about end-of-life care. And if they say yes, you are required to discuss each and every one of these things with them. If they then ask you about the End-of-Life Option Act or aid in dying medication, or you think they might be asking you about that, but you're not sure because maybe they're using a euphemism or maybe there's a language barrier there, then it is incumbent upon you to explore with them exactly what it is they're asking and what their concerns are. And we will talk more about that. Next slide. So let's look at what's happened in Oregon for a few minutes. Next slide. Who is it that asks for aid in dying medication? The 18-year experience in Oregon is pretty clear on this. And in terms of their state, almost all of these patients are Caucasian, but 87% of their population is Caucasian. Most of these patients have a Bachelor of Arts degree or higher. And they are, as you see, about 50% married or partnered. 90% or more are enrolled in hospice. So those are some key takeaway points that I want you to think about from this slide. Next. This just indicates that the overwhelming diagnosis among patients who request aid in dying medication is cancer in Oregon, in Washington, and in other locations. They do have a significant but small percentage of patients with ALS requesting medication and a growing number of patients with end-stage heart disease who are also requesting medication. Next slide. Prescriptions versus actual ingestions has been growing about 12% per year over time. Last year in 2015, they had about 214 requests and about 122 ingestions. The number of ingestions compared to the number of requests is usually around 50 to 60%, and it does vary a little bit year to year. So not everyone who asks ends up getting a prescription, and not everyone who gets a prescription ends up using the medication. Many patients feel it's a safety net for them. They just would like to have it there in case something happens. Others really intend to use it and do follow through. Next slide. This is just an indication from the time of the start of the Oregon experience in 1998 up through 2015, and you see a slow rise in the number of prescriptions that are requested and a steady similar increase in the number of ingestions that occur. Next slide. So back to reasons why people request this medication. We talked about who is it that requests, generally older individuals, generally cancer diagnosis, generally very well educated, very often empowered. These patients' primary concern as they express it, and this is data that's collected through the forms that are used by the Oregon Department of Health, they are concerned primarily about loss of quality of life, loss of ability to engage in enjoyable activities as they define them, loss of independence. These are really primary concerns. Much lower on the list are pain and financial consideration. And this is not an either or list, as you can tell by the statistics that are there. So although these concerns are on the spectrum for patients, their primary concerns you see are listed there at the top. Next slide. So concerns over personal well-being, fears and worries about poor quality of life, inability to pursue pleasurable activities, meaning in life becomes very, very important for these patients. And sense of identity can be lost as control and independence wane in the last phase of illness. And this is very, very distressing and a source of existential suffering for these patients that may go unrecognized by their care provider team, who may at that time be focusing on overwhelming physical symptoms. Loss of control over their situation. Early data from Oregon, when they did some of the earlier surveys on patients who requested aid in dying medication, indicated strongly that these patients felt two things. One, they were ready for death, and two, they wanted to control the circumstances around their death. And for them, that was the definition of a good death, a death that they could control and understand and comprehend and prepare for. And remember, these patients are on hospice. They are getting bereavement counseling. They are getting social support services. They are getting nursing services and having the opportunity to discuss and explore their fears and care. Next slide. Fears and worries, additionally, that people talk about, being dependent on others, being a burden, and fear of financial drain on family don't figure quite as prominently, but are important to explore with your patient who may be facing end of life, as they can be a source of suffering and distress. Next slide. So that's the end of my slides, and I'm going to turn it over to Ruchika, and then we'll be moving into the ethics and discussion part.
Well, thank you. So Dr. Duncan's overview provides a good segue into discussing some of the thorny, sensitive issues that are raised very often with regard to the End-of-Life Option Act. The End-of-Life Option Act, just like the end-of-life care and the end-of-life in general, presents a lot of emotionally charged situations for both patients, their families, as well as providers, okay? And where ethics comes in is with regard to, you have patients' rights. There's an interplay. There's a balancing act that needs to be achieved between the patient's rights, the provider's rights, the provider's duties and responsibilities. And when there are conflicts that happen between the patient, between the family, between that internal struggle that so very often comes up at the end of life in the minds of patients, in the minds of physicians who take care of patients in these very trying, difficult times, that's when there is a very fertile ground for potential conflicts to occur. Okay, so I want to go over some of these areas of concern and talk about them from the perspective of the law. And what I'm also going to do, I know that we are limited on time, but what I also want to do is to go into some of those situations that might occur or that might fall under each one of these different areas. Okay, so patients' rights. When we talk about ethical considerations when it comes to patients, this particular law, the intent of the law was to promote patient experience, patient autonomy at the end of life. That's the reason why this particular bill was passed, right? There was a majority of support for it. The time seemed right. Brittany Maynard's case had happened. And so you had a context where the public essentially was in support of having this particular option being available to them. But just as Dr. Duncan pointed out, the patient's right is essentially to have, the terminally ill patient has a right to request, not to get, to request this aid in dying medication from their physician. Okay, and nobody else can make this request on behalf of the patient. So many a times we get asked this question of, what if the family is in disagreement with a patient who is a qualified individual, meets all of the different criteria, and goes to their attending physician, has a conversation with them, and the attending physician is participating in the law. And the family is really uncomfortable with it. And they come to the attending, they approach them and say, well, doctor, he's depressed. How can you do this? I mean, this is, like killing him. So what do you do in that particular situation? Well, the law makes it very clear that this right is being provided to the patient. The family, even though they are an integral part of the patient's life and very much a part of the patient's end-of-life care and experience, they do not have a right to go against the patient. What those cries for help are with regard to are exactly that. They have not reached a place of comfort with the patient. They have not come to terms with their own understanding of where the patient is. They have not come to terms with how to proceed now that the patient is at the end of life and it's been recognized. So it's a cry for help from the family side, because they don't know what to do with their feelings, their emotions, and how to proceed from there, how to navigate that situation. And that's the reason why they are reaching out to the physician and saying, doctor, you cannot be doing this. The patient is depressed, whatever, right? So it's important to bear in mind that the patient is the one who is the driver of this. The patient is the one, the qualified patient is the one who asks that question, who comes to the doctor and initiates that conversation. And we'll get more into, perhaps in our question and answers, we can go into some of the other what-if situations that might arise, and what's the best way to deal with those conflicts or with those uncomfortable situations when they do arise. So moving on to the provider's rights, right? This law did provide a very particular right to the patient, but on the same hand, it also provided a particular right to the provider, okay? It provides protections, it provides conscientious objection rights to the physician who does not want to participate, to the nurse who does not want to share information with the patient with regard to the End-of-Life Option Act. And so providers have a right to choose not to participate. You might have taken care of this patient for 20 years, for 30 years, but you are not satisfied. You, as a professional, as a person, you do not feel that this is the right thing to do for this particular patient. Then you absolutely have the right to not participate in this law. And not participating in the law also means that you do not have an obligation to refer the patient to a participating provider. This is very, very different from other conscientious objection laws in the state of California. And it's really important to know that you have no obligation to give out information about the End-of-Life Option Act to the patient who asks about it, and you have no obligation, if you're not going to be participating in the law, you have no obligation to refer the patient to a participating provider. Okay, at the end of the day, it is a personal decision, a very personal decision that you as a physician will need to make with regard to participation. Okay, and even if you do decide that you want to participate, it might be that there are several patients who meet the minimum, patient qualifications and they're qualified individuals, but you as a physician, as their physician, you do not feel satisfied, that you don't feel comfortable that this is the right option for this particular patient. So as a participating physician, you might feel comfortable prescribing the medication to one patient, but not feel comfortable about prescribing the medication to another patient. And it all comes down to, that very sacred physician-patient relationship. And as you explore this with the patient, and as you try to find out from the patient the reasons for their request and why do they want to avail of this, have they gone through the other palliative care options, do they know about the other options or not? So it's really important as a physician to know what your rights are as well, okay? With regard to the provider's responsibilities, so of course, if as a physician you have a right with regard to the End-of-Life Option Act, you also have responsibilities. And specifically, if you choose to participate, you have certain responsibilities. And if you choose not to participate, you have certain other responsibilities as well. So first, I do want to mention, kind of going back to what Dr. Duncan mentioned, and the End-of-Life Option Act, yes, it does build protections for the physician who doesn't want to participate and doesn't want to give information about the End-of-Life Option Act to the patient who's requesting it. However, if the patient is terminally ill, then you still do have an obligation, even if you're not participating in the act, in the law, you still do have an obligation as their physician to tell them, to inform them about the spectrum of end-of-life care choices and options that are otherwise available to them. So palliative care is one of those particular options that is available to the patient, and you have an obligation to inform them. I cannot emphasize this enough because it seems like many physicians don't know about this particular law, and it's been enshrined in the Health and Safety Code 442. So it comes right before the End of Life Option Act, and it talks about every provider's responsibility and duty, the legal duty, to inform patients who are terminally ill about end-of-life options. Okay? Now, it might be that you're not participating in the law, but it doesn't mean that if you're not participating in the law that you stop caring for the patient, right? Caring has so many different dimensions to it. It might be that you're not going to be writing the prescription, but at the same time, you can still continue to act as that particular patient's physician and provide them with care with regard to their other dimensions that they are reaching out to you for. There might still be other things that you can provide to the patient in your capacity as their physician, especially as a long-term physician if you've had a relationship with them. So you do have a responsibility to not abandon the patient, and to make sure that the patient is still cared for, irrespective of your decision to participate in this new act. Of course, just in terms of a patient who's coming to you with a request for asking for the medication, make sure you have a responsibility. Make sure that the patient is truly informed and is making an informed decision, that it is a voluntary decision that they are making. And that's the aspect of care where decision-making capacity gets questioned at times. Is the patient truly depressed? If the patient's family is coming to you and asking you that, is there a serious concern there? Is there something to it? Certainly, explore that with the patient. And specifically, if you are going to be writing the prescription, you have an obligation to follow the process and to make sure that the patient is making a truly informed decision. We are all aware of the fact that patients come to us from several different backgrounds: socioeconomic, religious, spiritual, moral, and people have their own views and opinions with regard to how they want their care to be provided, right? Decision-making happens very differently across different patient demographics and different groups, depending on what their cultural and religious and spiritual backgrounds might be. So it's really important that, when a patient comes to you asking for the medication, that the patient is treated fairly, right? That you're treating every single patient with fairness, and that you're not discriminating against patients because they're making this request of you, right? So making sure that you are acting in fairness with regard to the patient. And then, just as I pointed out before, if you are going to be participating, there is a lot of, paperwork. There's a fair amount of reporting. There are forms that need to be filled out. So make sure, if you're going to be participating, make sure that you comply with all the legal requirements that the statute puts down as a part of the End of Life Option Act, as well as the organizational policy. And I do want to mention this here for Sutter Health providers, that Sutter Health has developed system-wide policies, and they are right now in the process of approval at the system-wide level. So if there are any questions about how this is going to play out in the hospital setting or in the outpatient setting, we can take that in the question and answer discussion as well. One of the things that, when we were looking at what is this going to look like within Sutter and how it's going to get implemented in the hospital system and how it's going to get implemented in the outpatient, one of the things that we emphasized was that a patient who wants to avail of this new law and wants to exercise their right and wants to have control over their end-of-life care and experience, if they really want to make sure that their wishes are carried forward, right? It's really important that before the medication is written out for the patient, before the prescription is provided to the patient, that there is an engaged discussion that happens between the attending physician who's writing the prescription and the patient about the what-if situations. Of course, the law asks that the provider, the attending physician, should have a discussion with the patient about, go and talk to your family about this. But the patient doesn't have any obligation to go and talk to the family about it, right? But there is a context to it, which is that once the patient takes the medication, it might be that it is their family that's at the bedside, right? And the family might pick up the phone and call 911, right? And so one of the things that we've done, in Sutter is that as a part of our checklist items, we have included this discussion that needs to happen between the patient and the provider about these what-if situations and emphasize the advanced care planning. So the patient should be encouraged to complete an advanced directive or complete a POST form so that if that situation were to happen, that 911 gets called, that there are those advanced care planning documents and the patient's wishes, those autonomous wishes with regard to their end-of-life care does get respected at the end of life. Because otherwise, the patient would just be, treated as a drug overdose when they're brought into the emergency room. Okay, so that's a really, really important point, and I think that a lot of patients do not think about it. There's a lot of buzz around the new law, and everybody is basically thinking about how can I get the medication, but there's also what if it doesn't go in the right direction, and what's your plan B? If your family calls 911, right? The other thing that I also wanted to point it out here is providers should know the law, because you are going to get asked by your patients, by patients' families perhaps, about this new law. So know the new law and make a decision for yourself if you're going to be participating or not, because you will need to know how to respond to that request when it comes to you in that moment when you're completely unprepared. Okay? As we talked about, the End-of-Life Option Act presents a very fertile ground for potential conflicts, because there can be a lot of disagreements between patients, family members, between medical team providers, third-party vendors, pharmacies, who knows what, right? And so how are you going to be managing these potential conflicts? Just some resources, and again, depending on whichever institution you're a part of, there might be different kinds of resources available to you. Within Sutter Health, we do have, certain resources available, but I think, these resources, I would imagine, are available at any institution. So, of course, if there is a disagreement between patient and between the patient and the family, it's really important that there is adequate support that's provided for the patient and the family members, whether that's through spiritual care or it's through social work, that should be made available to the patient and the family. Within Sutter Health, certainly within some hospitals and some entities of Sutter Health, we do have ethics services, and we are great, if I may say so myself, at resolving conflicts, or that's at least what our expertise is, and so that is something that an ethics consultation service will be able to provide to patients, to providers in times of conflict. Every hospital, every healthcare institution does have a risk management arm, and if there are conflicts that have a legal implication, make sure that you involve risk management into those discussions. And of course, at any point of time, if you're trying to navigate those waters of conflict, you can always talk to your manager, or again, within Sutter, we also have the employee assistance program if it becomes too much for you to deal with. One last thing before we wrap this up is to talk about, the emergency situation. Yes, it will happen. We looked at the data from Oregon, and, there's really nothing that's been published. Dr. Duncan, you correct me if I'm mistaken. But being prepared that there will be emergency doctors who will see these patients, because there will be, at some point or the other, there will be family members who will bring their loved ones into the hospital after the patient has ingested the medication. And just thinking about what is ethically appropriate to do in those situations, if the patient has ingested the medication, gone through the whole legal process of getting the medication, and they have documentation that they actually did go through the process, and they have advanced care planning documents, and they've done everything in compliance with the law, then it would be ethically appropriate to respect their wishes. That was the intent and the spirit of the law. And so it would be ethically appropriate to do that. Of course, we do know that patients can always change their mind. It could be that the patient has a bowel obstruction, and you know what? They haven't lost the decision-making capacity, and they wake up, as it did happen in Oregon. There were 6 patients who had a bowel obstruction, and they did wake up, and they didn't want to go through with the process again, because they saw it as a sign. So that can happen. So if the patient has capacity and is able to participate in their treatment discussions, absolutely talk to the patient, find out what they want, and then proceed with honoring their wishes if they do have capacity. So just to wrap up, some key points with regard to the new End-of-Life Option Act. We know that providers and healthcare organizations can participate. Participation is optional. There are clear patient eligibility requirements. There's a very strict process for how requests must be received, documented, as well as witnessed. There are specific forms and processes as well for tracking, and ethical considerations and conflicts can be anticipated, and you need to have your resources ready if it does happen, okay? So just one last slide on, just making sure that we're all on the same page when it comes to not just this End-of-Life Option Act, but with regard to end-of-life care in general, is to recognize that the end of life is very complex. It is very emotionally charged for patients, for their family members, but also for the physicians, also for the healthcare professionals who take care of these patients day in and day out. Sometimes we think that this person is a doctor. They must be used to doing this. This is a palliative care physician. This is what they do. No, but it takes a toll on that professional as well. And every single conversation with the patient, with their family, creates those platforms for discussion, but also provides an opportunity for peace, for planning, and for closure. And so we all must be mindful of the experiences that a community of professionals, as well as our community of patients, go through at the end of life. Thank you. Okay, so I think we're ready for questions. You do have some index cards on the table if you'd wish to.
Thank you. Thank you for a great presentation from both of you. I'm wondering, as you know, this is the most populous and diverse state to have this law be enacted, and and it's supposed to sunset in 10 years. So I'm wondering, what kind of data are we keeping to keep track of any potential for abuse, so that if in 10 years we want to renew the law, we can tweak it appropriately? Can you talk about the data that's being kept differently in California than prior states have kept?
So the data that we're collecting is specifically outlined in the legislation, and it comes from the forms that are going to be turned into the California Department of Public Health. And it is fairly broad. In addition to that, of course, there's regular medical charting. So in situations where there's a question of any abuse or misuse, or someone raises a question about it, then the first thing that's going to be done is to be sure that the patient and the providers that were involved in the case did comply fully with all of their responsibilities as written out in the legislation. And then probably or possibly there will be a chart review as well. So the better the documentation in the medical chart about the patient's motivations, about the opportunities for exploration, about the informed consent aspects of the case in particular, the stronger that will be for that provider as they are going through the question process. So that's how the data is being collected. For those of you who may be participating, I want to really encourage you to not leave the last form until last. it is the most detailed form. And it is the one that you submit after the patient has died, and you're filling in what their death was due to and whether or not they ingested the medication to the best of your knowledge. There's a lot of demographic information in that form that is being collected at that time. So please, as you go through the process early on, please look at and really think about that form so that you can gather the answers to those questions before the patient dies. The questions are fairly detailed. Yes?
Is the decision to participate at the individual doctor level, or is it at the medical group or the institution level? And how does that get parsed out?
So it is both. That's a very good question. So every organization can create a policy, as I said, that's consistent with their mission and values. Catholic healthcare organizations, for example, will have a non-participating policy by and large across the states where they are working in this area. Other organizations, such as Sutter, have a participating policy. Within those organizations, every different provider and medical personnel who are involved with these patients who are terminally ill has their own right to conscientious objection or participation as they may choose. Now, for policy situations where there's a non-participation policy, providers within that organization, regardless of their preference, cannot participate according to the definition in the legislation with a patient who requests this option. They can discuss it with their patient. They can refer their patient to someone outside that system, but they can't go through the process. They cannot be the attending physician. They cannot be the consulting physician. They cannot fill out the forms or send them in or write a prescription. And that organization has the option and the right to impose punitive measures on providers who do not comply with the policy that has been made known to them. It's very complex.
Is there any work done in providing something similar to patients who are dealing with a neurodegenerative illness like Alzheimer's?
So the question is, what about patients with neurodegenerative disorders such as Alzheimer's or ALS, where they've lost the ability primarily to self-administer the medication in the case of ALS, or in the case of Alzheimer's, where at the time they have a prognosis of 6 months and might become eligible, they no longer have capacity for decision making. It's foreseeable that we will never have an option appropriate for Alzheimer's patients in that situation because of the moral and ethical challenges and because of the clinical challenges of determining informed consent for a patient carrying that diagnosis. And because you need to demonstrate true informed consent for these patients, it's very hard to imagine that would ever happen. For the ALS patients, there's obviously, this is an ongoing area of discussion. We are fundamentally different from Oregon in this setting because of our requirement that medication be self-administered. It is an additional protection for those with disability impairment, and I think time will tell how things play out over time and whether or not we see large groups of patients who have inability to self-administer but do retain the ability to ingest, whether or not there is an outcry or a push or a public movement in order to revise any future law. But at this time, there are discussions, things are being written, but there isn't a formal process in place that I know of. And if anyone knows differently, please let us know.
In response to that question that you gave, if a person who is beginning to develop Alzheimer's writes an advance directive that says that they want to participate in this end-of-life activity, would that be more likely to show that they had capacity then?
No, because what happens, the description of eligibility is very specific. So at the time that you are making the request for the medication, you must have a 6 months prognosis and have full capacity to make the decision. And because Alzheimer's is slowly progressive, no matter what you've indicated your wishes are a long time ago, this particular option you wouldn't fulfill eligibility criteria. Yeah, it's fairly black and white.
Yeah, I have a question. Can I bring my medicine to the hospital and take it here?
So the policies are currently in the process of being approved at the system-wide Sutter level. So I can't speak to what the position that Sutter Health has taken with regard to taking medications in the hospital. It will happen in a very restricted manner, only in very special circumstances. Patients will not be able to be admitted for the specific purpose of requesting the medication or for the specific purpose of administering a medication that they already have. So it is going to only be allowed in very special circumstances if the patient is not able to take the medication at home, or if they are not, able to be discharged home, only under very special circumstances. Yeah,
and demographically, these patients just tend not to want to be in the hospital. They want control over their end of life circumstances. They generally have pictured that in a non-healthcare setting, and overwhelmingly in Oregon, the deaths occur in the home.
Yeah, and also just want to add that, with regard to end-of-life care, any of these patients, the ALS patient or the Alzheimer's patient, all of them, they still would have the right to receive comfort-focused treatments with regard to, their end of life, right? So that is definitely an option that is going to be available for all patients, regardless of their capacity and regardless of what, they have put down in their advanced directives. Yes.
Two questions. Could you define what a provider is, and also define what the drug is and mechanism of action and how long it takes?
Sure. So providing end-of-life care, the only people who can participate and write prescriptions are physicians. So you have to have an MD, and that's part of the law. The medications that are being used are several. The primary one that's been used most recently in Oregon and the most experiences with it is secobarbital, which is a barbiturate, and it kills by respiratory depression. It is not always available, and there are alternative combinations or compounded medications comprised of a barbiturate, a narcotic, and chloral hydrate, sometimes that are specially mixed and prepared for the patient. The medication is almost always taken in a liquid form.
I hope it's a simple question. You might have answered it already earlier, and I missed it. But the one thing I didn't understand is why a provider, if he or she did not wish to participate, may choose to not refer the patient. Because, for example, I'm the patient and I've had a doctor for 25 years. The doctor says, no, I can't help you with this. Do I go home and Google?
Right, so the question is, as a patient, how do you get information if your primary provider is uncomfortable providing you with information or with the referral? And you do have to self-advocate at that point if that information is not obviously to be had within your healthcare system. For participating healthcare systems, there will be, as far as what we're seeing being developed across the state, there will be services and information available. In other words, there may be a social worker or a palliative care nurse or caregiver who would be available to speak with you about this option and to give you guidance in that regard. For those in smaller clinics or rural areas, we don't know yet. We do anticipate that there will be lots of questions around access over time because of disparities in distribution for hospice and palliative care. And what we hope is that the passage of this law, more than anything else, will allow all of us the opportunity to think about end-of-life care and how to make it excellent for everyone, and for those providers who have not taken the time to get the training and the tools that they need to discuss and describe and be thoughtful about engaging with their patients around listening for them and helping them understand their different end-of-life care options. We really hope that they will take the time to do that, and that we will see a better use of language that's more patient-centered in this area, and that we will also see these discussions happening earlier on. In other words, rather than waiting until a crisis moment or a terminal illness, can we please start planning for end of life a little bit earlier with advanced care planning, with conversations over time, with values and wishes and goals that are not medical goals but are life goals, so that decisions can be made that are particularly appropriate for those patients.
And I'll also just add, with regard to your question, so Sutter Health as a system will actually connect patients with participating providers if a patient contacts the system.
Okay.
Okay. Yeah, I'm a non-clinician, but from the patient-family perspective, in terms of other options at the end of life, how open or sort of cloaked are discussions around palliative sedation and voluntary stopping eating and drinking, in terms of providers maybe wanting to give patients, or patients wanting some control, but perhaps they don't qualify under the law or don't want to go that route? Is that a kind of wink-wink conversation, or can that be an open, here are some things in your control?
Want to start with that, or do you want me to
well,
tackle
well,
it?
certainly, I think that providers, again, providers need to have the knowledge about it in order to actually have a conversation comfortably about palliative sedation or voluntary stopping to eat and drink, right? So the first thing is empowering our physicians, empowering our providers with the right knowledge and the tools and resources to navigate and have those conversations with patients, and to even know if they meet criteria or not. Are they there yet or not? But again, I can speak to the Sutter Health position, which is a very open conversation about palliative sedation or voluntary, stopping to eat and drink, and really supporting all of the different end-of-life options for patients.
So on a pragmatic basis, what is the process for trying to guard against people who are maybe making this decision because they feel guilt-tripped, whether by their loved ones, or even if the loved ones aren't guilt-tripping, they just feel guilty? For example, is there a process in place where the physician will counsel the person alone, away from all family members? That's my first question. You're nodding, so yes. And the second question is, the most compelling ethical reason against this law that I've heard is that people on the other side of the issue say that the number of people who will actually be eligible for this law and take advantage of it is a lot fewer than the number who could potentially encounter abuse. And so their position is, if there was a fail-safe way of avoiding abuse, sure, but there isn't. Therefore, how do you justify this ethically if you can help, let's say, 100 people legitimately die a year, but 200 are going to be pressured and abused and pushed towards ending their life prematurely?
So that's a several-part question, and let's break it down a little bit. First, part of the requirements and responsibilities of the attending physician is to engage and speak with the patient one-on-one. So they can't have other family members in the room, and they have to confirm that the patient is not making the request under coercion or pressure, and it says so several places in the legislation itself. So the burden really is on the physician, attending physician, and the consulting physician to make this determination that the patient appears to be, to the best of their knowledge, making an informed decision, and also the voluntariness of the decision. Looking at the Oregon data, again, demographically, the patients who are requesting this type of aid in dying are a very personally empowered. Again, their definition of an acceptable death process is one over which they have complete control. That is not going to be a choice that is at all attractive to many people who will take very different approaches. For example, I'm just going to let things come as they may, or I'm going to let death take me when it happens. So we're talking about a very narrow group of individuals who tends to self-advocate vociferously and historically has been fairly educated and proactive about this choice. Can it be perfect and 100% guarantee? Nothing's 100% guarantee except that we will all face death, to my knowledge. That is the best of my knowledge, which is why I think having these conversations and giving patients the best opportunity and families the best opportunities that we can to really explore what are the different types of supportive care that they can expect, what really is good palliative care, and in a setting where formal palliative care services are not available, which comprises most of the counties in our state, or many of them, how do we provide some kind of palliative services? How do we expand that workforce? These are the questions that I know Dr. Mishra and myself, I'm very interested in. What do the next 20 years look like in terms of creating good end-of-life health care for everyone and making that available, because it isn't right now. And I hope that these discussions will help us all to recognize that, to think about it, to get the skills that will be needed to provide good, compassionate, thoughtful, patient-centered end-of-life care. And that will certainly include discussions about palliative care and hospice and voluntary stopping of eating and drinking and so on, as are described not only in this legislation, but of course in AB 2139 that you heard about tonight, Health and Safety Code 422, I think it is, yeah.
If it's any law that before patient takes the final dose, the patient has to have a witness at the time or somebody with, or have some arrangement, what happens after? If not, I can see that patients with really crappy home, they don't want to die at home. They want to go to the Golden Gate, see the sunset and die. And patient dies. And then people walk on the street can find the dead person, call the 911 or coroners, and all the things can happen. So some kind of a law to protect that.
Yeah, so it's interesting that you asked that question. So the law actually does not talk about a requirement to have a witness when the patient takes the medication, and yet the law does comment about, not taking it in public. Okay, so, being on the street and taking it, that is not basically a part of the law. Yeah.
Yes, it says specifically the patients have to be counseled to not take the medication in public. Most of the patients overwhelmingly are involved in a hospice program, more than 90%. So almost always there is a very definite anticipation of how this patient's dying process is going to occur, so that when the death actually happens, it is not unexpected, and they are normally in the course of hospice. Of course, the hospice nurse will pronounce the death, and the funeral home will be called at that point. There may be a handful of cases where hospice isn't involved, and in that situation, we're going to rely on best practices, on hopefully an existing POLST form, on the last attestation to indicate the patient's wishes so that the coroner does not have to evaluate those cases unnecessarily.
If a mental health consultation is called for, does the provider have to be a psychiatrist as opposed to a non-MD mental health professional?
Licensed psychologist or psychiatrist is required. So does not have to be an MD psychiatrist, needs to be a licensed clinical psychologist at the minimum.
I have two questions. I'm a non-physician. I assume that terminal means that the disease would progress on its own without treatment. Correct? When you say it must be terminal within 6 months?
So terminal is a term that is defined differently in different places, and certainly defined differently in the minds of everyone who uses that word. But for the purposes of this legislation, it means that the patient, given the disease process that they have for which they are seeking aid in dying, given absence of other extraneous factors, they would naturally progress to their death in about 6 months.
Okay, so would there be physicians that disagree that that patient's not terminal because if they had this chemo, which is going to make their life awful, that they're not terminal within 6 months? And is that something that patients are going to have to deal with more because of this law?
Let me say that, again, that most of these patients are already enrolled in hospice. They are mostly they're entirely hospice eligible by definition of their 6 months prognosis. It is their choice whether or not to pursue curative or cure-focused treatment at that time. And we all know of some cases, many cases in fact, particularly among younger cancer patients, where we are really treating very aggressively, some would argue too long. Right up until the moment of death sometimes, creating many missed opportunities there. But that is the patient's choice. So if they are going to pursue this option, they would naturally have given up aggressive curative treatments, but not treatments that are designed to create symptom relief or functionality for them in the context of their dying process. And that may include medications that are directed at their disease process, like steroids or something, that are helping to modulate their disease process, but also have a beneficial effect on their symptoms and functional aspect. Do you want to touch on that at all?
Your group has issued some wonderful guidelines, and so does the California Medical Association and the CDPH about the process. But no one talks in detail pharmacologically about what the physician should be prescribing, the dosing. Where does a provider go to get that information?
Good question. So there's an advocacy organization, as you know, that has much of this information, but the information is available from colleagues and providers and from Lonnie Shavelson, who has a specialized practice in the East Bay, who is providing coaching. There are others, I think, in the systems who will become mentors. Best practice tells us that any provider who is for the first time engaging with a patient to participate in the End-of-Life Option Act, because not only the logistics are going to be challenging and numerous, but also because the emotional and moral journey can be very challenging. It's really good to have a mentor colleague to work with on that. So that information can be found, and I'll be happy to talk with you more about it. The protocols are very straightforward. The pharmacies that are participating to provide the medication for legally received prescriptions, they have information about this as well. There are discussions and papers about how to avoid problematic side effects or difficult ingestions and even prolonged dying times. So this information is available. Yeah.
And I'll just add that within Sutter, again, there was a lot of work done with regard to standardizing, not just the processes, but also checklists, and also providing support to the physicians who will be participating in the act. And so within EHR, there is an order set that will be made available once the process is started by the physician. So that information is going to be part of EHR and available to physicians who will be participating. And then Sutter also has some mentor physicians, palliative care physicians specifically, who are championing the process just in terms of what education the providers need who are going to be participating. So that's also another effort that's going to be provided as an advisory group to participating physicians.
Yeah, and like all things in medicine, it's very likely to change over time. And I think I've had the question, why isn't the protocol written out in the legislation so that it's clear and fair for everyone? Well, it's going to change over time. and medications change, manufacturers change, new things come along, our ability to administer them via a different route and so on, or, it's liquid now and it was granules before. So of course, none of that is in the legislation, and that's for a very good reason.
Provider has to be an MD, but I'm wondering, is there any oversight in terms of providers who normally wouldn't be dealing with these kinds of issues? I mean, might it hypothetically be an ophthalmologist, an OBGYN, dermatology? I mean, it may sound sort of ludicrous, but I mean, are there any limits in terms of who might do this work on this with their patient or address it?
That's a very good question. So the way the legislation is written, the attending physician has to be treating the patient and also caring for them in the capacity of managing their terminal illness. So usually that's not the ophthalmologist, because the ocular things are more often a manifestation of the disease, but not the primary disease. Occasionally it might be a dermatologist. I could certainly see that if someone had a cutaneous lymphoma or something like that, where it might be a dermatologist. But generally speaking, there's a physician caring for the end of life disease process.
I remember years ago when Tim Quill wrote his first article about prescribing a fatal dose of barbiturates for a patient, and there was a lot of discussion about doctors who did that, patients who felt so much better having that prescription at hand, even if they weren't going to use it. But could you please comment on the current cost of the various alternatives?
Fortunately, yes. So the generally preferred drug, which is Seconal, is manufactured by Valiant, and it's about $3,000 for the dose. And whether or not insurance is paying for it, just it's dependent on the insurance provider making the choice of whether or not they're going to cover it. Medi-Cal policies for the state are being developed at this time as far as coverage of the drugs. The compounded liquid formulation, which is a set of several drugs, these drugs are very, very old, $400 to $500 for the full compounding for the patient and mailing out to the patient's home. So vast differences. Again, I think this speaks to the issue of people are looking for other ways to make this accessible for patients and to not have so many barriers. We know right now that there are researchers in Washington and elsewhere that are trying to look at and create better, safer, more comfortable regimens that will be cheap and tolerable and safe. And I expect that we will hear that information as it becomes available. Good question. Right. Many do. You're correct. So many of course die naturally from their disease process before they ingest. Many of them decide not to. It's a choice they have up until the very last moment of their life. Of course, the Oregon and Washington data are really, really similar, in fact, in terms of patient characteristics, in terms of rough numbers of prescriptions requested, percentage-wise from total deaths, and so on. So the data is really surprisingly consistent. Those states are also demographically very similar and very, very different from California. So although we can look to that experience, it's harder to extrapolate and say what's going to happen here. I would also never speculate about the reasons why a drug company raises the cost of its medication.
Is that also legislation, though? That's what I'm not sure if it was a legislation saying that said it's $3,000.
No.
Can I? Might I tackle that?
What the market will bear, I think, is where that is.
Can I tackle that for just a second? One of the things that's being recommended, we've learned a lot from Oregon just because of that data. And the strongest recommendation now is don't have the patient get the medication until they're really within 48 hours of the time of making that decision. And there's an easy way now to get it FedExed over. So that really what is suggested to say to your patients is, first, this is a dangerous medication. You don't want to keep it at home. Therefore, keep it at the pharmacy. The order goes in, and the pharmacy can ship it to you the day before your death day. And so a lot of that data, I think, will change in California as we've learned specifically from them, from the other states, about better ways to do this.
Good point.
Yeah, we lost the thread a little, so I feel bad because people are on this. But I was bouncing back to Gail's question a couple minutes ago. Obviously, there's obstacles to finding providers who are able to do this. I understand why your eye doctor can't give you this prescription. If your long-term oncologist says no, and also says I won't refer you anywhere else, how you then find another oncologist to start providing your care from scratch so that they can be the one to give you the prescription?
Yeah,
right,
so that's,
right, and
you
what
know,
are those
that's
time requirements?
That's one of the million-dollar questions. But I think that patient advocates and many, many others would feel that it would be very appropriate to assist and help that patient along their way, at least to get the information that they need and at least to be able to make the request in the way that is appropriate and to explore eligibility and so on. So yes, at that point it might require that the patient self-direct to another attending physician who is a participating provider. And at that point, because the transition is going to be from caring for the disease process and prolonging life potentially to accepting for and planning for the end of life, it can be a smooth time to transition from one provider to another who is very focused and specialized on end-of-life care.
Yeah, I mean, it's a big issue, just in terms of provider participation. I can tell you that there are very, very few physicians within the Sutter system who are willing to participate and write the prescription for the medication. There are also challenges with regard to pharmacies that are participating at this time. It's not going to be your regular Walgreens or CVS that's going to provide the medication. So there are several issues with regard to the implementation of the law and the logistics as it gets rolled out. And we'll basically just have to see and learn from, what's really going on, who are these patients, and one of the things that, Dr. Duncan and I talked about was over time, patients, their families, as well as individual physicians will know more about the law and will reach, a place of comfort with regard to are they participating or not. And probably, that may change as time goes by and as people have more information and knowledge about it as well.